So our next speaker is Dr. Kevin Mackey, and he's going to give us an overview of the alternate behavior pilot project in Stanislaus County. So anyway, real quick, Dr. Mackey is the medical director for Stanislaus County EMS Agency and also medical director with the Sacramento City or County Fire. Sacramento County Fire. He likes to be called Kevin by the community paramedics that work with him. I've known Kevin for a whole lot of years, probably about the same amount of time as I know my colleague over there, Matt. And a more passionate person in reference to this project you will not find. But what I need to find is his presentation, because he changed it.
So as the speaker said this morning, following Anna was brutal, following Matt is brutal. So thanks, Matt. I appreciate you setting me up. Yeah. So say hi to Jeff Beeson, right? Jeff's still down there? He's not? Oh, he's not with MedStar anymore, is he? Evolution? Oh, okay. I know there's a big shakeup. Scott Bourne's no longer there. Okay, so I'll be using a pointer, and I do like to roam as well. I'm similar to Matt, and I've put some financials in here as well, which Matt kind of alluded to. But I'm going to move fairly quickly. So first of all, I have no disclosures. It's kind of a habit. I start out every talk, not with that particular slide, but I don't work for anybody other than Mountain Valley and Sacramento Regional Fire, but I don't get paid for this project other than my usual duties. So this is a great saying by Einstein, and it's really true. It's kind of the theme of the day, right? All right, the definition of insanity is doing the same thing over and over again, but expecting different results. So we have to begin to do things differently. We've been talking about that all day, but I wanted to start with this slide. This is a picture I took with my phone, taking out all HIPAA stuff that I could. This is a day in my department. So I'm going to point out the important things. The green things over here, these are all psych patients, right? And so there's roughly 13 or so patients in the department at the time I took this picture. I was, in fact, managing all of them, almost all of them. And you can see the time range is 91 hours. This person been here 91 hours all the way down to about 4 hours. So the shortest time frame at that point when this slide was taken was 4 hours. The longest the person been there more than 3 days. So does anyone else in here have people in their emergency departments and you've seen there, right? You've gone home, you've been with your family, you're on your 2-day off, you come back, and oh, the same person's there. So that is not uncommon, unfortunately. And then this is another picture from my shop. That's a real picture. I didn't like Photoshop that stuff in. That was a real day. That was, I know, Dave shaking his head. He's our EMS administrator for Sacramento. This is Kaiser in South Sacramento, which is my shop. And there really was a day when we had all of these folks here, and we were looking for one more place. And I was walking in to go to work, and I almost started to feel like, golly, today's a really bad day to be here. I think I'm going to be sick. But I think I've been seen by 4 people walking up to that point, so I couldn't call in. That was a bad one. That was a bad one. This is a little unusual, but it was a doozy. So we have to build a better mousetrap. We have to begin to utilize our providers that are there 24/7, 365 in a different way. So I'm going to stop for just one moment because I want to make sure I did not forget to do this. I do have some of my mousetraps that we've built better, right? So Dennis Flannery is back there. He's one of our community paramedics. Sean Mangskow, who's videotaping me. Hi. Hi to Sean's family. So he is also one of our community paramedics. Rich, who's trying to hide his face, is our EMS administrator, massive supporter, and then Mike Corbin is our CS manager for AMR. So I'm particularly thankful for these 4 gentlemen, plus the other community paramedics that could not be here. Kelly and John are holding down the fort. We are a 24/7, 365 operation in Mountain Valley. We never close our doors. We're open all the time. So building a better mousetrap. So, and then this is a saying from Socrates, you know, the secret of change is to focus all of your energy not on fighting the old, but on building the new. And I think that's what we're all trying to do here. So we need to find someone who can come in and save the day, and that is our community paramedics. They are coming in and they are saving the day. So here are, well, two of them who couldn't be here. I told you that John is currently in the battlefield right now. Christy has gone on to other pastures. I wouldn't necessarily call them greener, although she would say they're greener. She's gone back to school. And so that'll be one of the things I'm going to ask toward the end of this. And that is that we have to figure out a way to continue to build community paramedics. We are losing some by recidivism. And so we need to figure out a better way to do that. So, re-engineering our resources. Up until this point, and I was a paramedic for 10 years, I was a hammer. I had one purpose and one purpose only, and that was to take people to the emergency department. And we've heard all day about turning these paramedics into multi-use tools, right? So multiple things we can do. It's been really exciting to hear what everyone's doing all day. I think all the projects are really amazing. I think mine's the best. So project number 12 is ours. So screening for medical clearance of behavioral health patients. This getting back to that first couple slides I showed you. These are the folks we had to get in the room. And you've heard all day, and I hate to beat the drum, but you really do need to figure out who needs to be in the room and get it pretty close to right out the gate. And we invited everybody far and wide. So we, of course, were there, and AMR was there. But then we figured out we better get law enforcement, public health, behavioral health, and our hospitals in the room all at the same time. So we started holding meetings really early on, really early. And it was a massive fight. There were a lot of mountains to get this project off the ground. This is our decision process. So some folks are referred to as community paramedics. I have referred to them as community paramedics, although mobile healthcare providers or mobile integrated healthcare paramedics is a more national term. So when you see MIHP up here, this is something that I kind of browbeat into them. They call themselves both. This is it. This is our entire decision scheme. The way paramedics, the way a patient, gets into our system is one of three ways. First and the most common is the 911 system, but the second way is through our law enforcement. That was an unanticipated, massive benefit. I will never forget, Dennis, was I riding with you on the first day when we came off the ground on September 25th? It was either you or John that I was with, and I never will forget the look on our Modesto police officer's face when he said, so what does this four-wheel drive do, and what are you guys doing? Oh, well, we kind of try to help steer behavioral health patients away from emergency departments, if they can, directly to behavioral health hospitals. And he said, can I send that out on my MDT, which is mobile data transmitter? I'm like, no, Chief Carroll probably doesn't know about this yet, and it's going to go crazy. So the moment that happened, but our law enforcement partners have been amazing in this. And then also, of course, the third way, which we also did not anticipate, is our behavioral health hospitals themselves will call us. So imagine this. You get a patient that walks in through your front door, through your behavioral health, because they know where it is. They've been there before. And they have a crisis. That person needs to be medically screened in some way for safety before they can stay there. So prior to our project, they'd call for an ambulance. The ambulance would transport to the emergency department. They would take up a bed at the hospital for anywhere from 4 to 91 hours, and then they're transported back. So and that cost is incurred by the county. So the county pays for that ambulance transport to and from. So now they just call us directly, and our paramedics will go directly to the hospital and screen them right there where they sit, which is fantastic. It saves the patient time, saves the hospital's time, and all this stuff starts to add up after a while. So once our paramedic, our community paramedic is called, then they go and they do their own assessment after one of our paramedics has generally been on scene. Our paramedics, the street paramedics, do a screening for health safety. That's pretty much their job. They institute the behavioral health paramedic who comes out, and they do their evaluation, which is a separate screening protocol. I'll show you that briefly. And then they make a decision. If the person has failed any part of what I call the well-person algorithm, which is kind of like the vital signs, that person's screened out of the process immediately. They go right to the hospital. Once they're deemed to be medically stable, then our community paramedic does a more detailed assessment of their psychiatric issues. Hunting specifically for things that are unanticipated that could be dangerous. One thing's big is alcohol. So alcohol withdrawal, DTs, is a fatal process. So we screen them with something called a CEWA score, which is a validated scoring system to predict someone's risk of going into DTs, even if they're not drunk right in front of you. If they are intoxicated or have been drinking, our paramedics will administer a breathalyzer to determine that they are currently not legally drunk, 0.08. And in addition to that, they'll determine if any lacerations or self-induced cuts on them are dangerous enough that they will need repair. And they'll also hunt for those unanticipated overdoses, things like tricyclics, aspirin, and Tylenol, the things that are going to kill you. Those things they also screen for through conversation. And Dennis and John will tell you, and so will Sean, will tell you that they spend about a good half hour developing a rapport and a relationship with these folks. And we've done it in such a way and learned how to do it in such a way it's out of the eyes of law enforcement. Oftentimes law enforcement will be there, and you guys will correct me if I'm wrong, they'll tend to shut down if law enforcement is standing right there. So you get them in the back of the ambulance, have a calm conversation, and these folks really start to open up. And they'll tell you what's going on. So once we screen them through the mental health process, we find out if they're eligible, and if they're eligible, then they go to our psychiatric facility, which I'll go to in just a second. So this slide kind of goes through what I just talked about. First step is well-person algorithm. Are their vitals normal? And then the second step is a mental health clearance. In our county, we have to do a little bit of an insurance evaluation. The reason why is because we have a large behavioral health hospital. As a matter of fact, it is the largest in California, has over 160 beds in Modesto, that decided because of federal regulations they could not play in this process. There are some EMTALA violations that would happen if we transported them directly to that hospital. The one hospital that is participating is our county hospital that can only take uninsured, indigent, or Medi-Cal patients, which I thought that's a home run because those patients are often the hardest to dispo, but they're also a little bit fewer in number. So I had to do my San Diego reference, right? So our Ron Burgundy, 60% of the time we get it right all the time. Just this slide will show you that for an average month, our paramedic impression through AMR is right around 97 patients have paramedic impression of psychiatric illness, and we engage our mobile integrated healthcare paramedic about 52 of those times. So it's about 60% of the time we are getting engaged in behavioral health patients in an average month. Now the numbers. These are big numbers, really exciting. This is much higher than we ever anticipated. So this is current as of September 18th, just a couple of days ago. Our community paramedics have evaluated 620 patients in the roughly 12 months that we've been up and running. You'll see from top to bottom, those that failed and fell out, 255, eligible, not enrolled. I'll explain that a little bit more in just a second. That's mostly insurance. Eligible, enrolled, 167 patients total so far. So if they fall into one of those two categories, they go to the emergency department. Currently, we have no other options. If there's not a bed, or if they don't have the right insurance, or they have insurance, then they have to go to an emergency department. If, however, they are indigent or Medi-Cal, and they pass both the well-person protocol and the mental health screening algorithm, then they can go to the psychiatric facility. Sorry for the reference, but that's true. So here's some numbers to show you about why people fail the mental health clearance algorithm or the well-person protocol. It's vital signs is the biggest number. They have some sort of an unidentified medical or traumatic complaint, and age is way at the bottom. Our age ranges are 18 to 59. For eligible not enrolled, the biggest reason why they can't go is because we don't have beds. There's no beds available at the facility. Second biggest is insurance, and then we have this thing called a CERT blacklist. A CERT blacklist means that they've gone to our psychiatric facility before for our county, and for some reason or another they acted out, misbehaved. Something happened where they just said, you know, we just can't handle this person at this facility. And then finally, the big one, eligible enrolled, 167 patients. The vast majority of them have been transported directly to our county facility, have successfully been hospitalized there or discharged from there, and have not had to go to an emergency department. We're required through OSHPD to follow them through 6 hours. 6 hours, I follow them all the way through until they go home. And I want to make sure that nothing happens in the psych facility 2 days into their hospitalization. So those 8 patients that fell out, those 8 patients were, you saw them a little bit earlier, a long time ago actually. One was incontinent. Dr. Kaufman talked about this. One was incontinent, one required CPAP. So they weren't something that our mobile integrated healthcare paramedic missed. It was something that happened after they arrived at the facility. So average ages, right around in the 30s. Some more demographics. Caucasian, more than Hispanic, more than our African American population, and finally, English speakers are the higher population. So here's some interesting things, and this is where we're going to get into the money of it. So these are where folks were transported. You'll see Doctors Medical Center here. They are the owner of that large psychiatric facility. So that's where the vast majority of patients go. Then you have that other big chunk that ended up at CERT, which is our county. CERT is our county psychiatric facility where we are transporting our patients to. And then just a smaller number were MPD transports finally to Kaiser and to Emmanuel Medical Center. Small numbers. But this is probably the money slide. This slide's extremely important to us. So these lines across the bottom go by time from arrival at their facility to disposition. So this is how much time our hospitals are going to spend dispoing a patient. We follow those numbers through the months, and you can see that if they go to Memorial, which does not have a relationship with a current psychiatric hospital, these patients sit there for sometimes a long, long time, compared to corresponding dark blue, where they were disposed much sooner, much sooner. But take something more from this slide. If we could transport directly to the psych facility that doctors is associated with, that number wouldn't even be there. So these patients still took up time in emergency departments. That's an important thing to remember. How about our faithful customers? How many return visitors do we have? Look at this. In March, April, and May, not even one. So you would think that in our project we'd have multiple repeat visitors. And it turns out we don't. We had a spike in February, right around in the winter months, but we don't get a lot of repeat visitors, which is intriguing to me. I expected the complete opposite. Finally, this really is about the money. So we started before our project, and we sent 6 model patients to each of our emergency departments, and we asked that hospital to tell us not how much you would bill and not how much you would get back. How much would your actual charges be to have a patient housed with these complaints? So simple things like psychosis, off their medications, depressed and suicidal, things like that. How much would it cost your hospital? And we averaged those numbers together, and we came up with an average of about $7,600. You'll see numbers all over the map throughout the state for that. You'll see 2,500, and you'll see as high as 10,000. But it's 7,600 is in the ballpark. So if you take our project and you multiply that by the 159 patients we successfully kept out of the emergency department, in the first year, our healthcare savings, real dollars, to our hospital was over $1.2 million in just the first 12 months. Now, remember I told you we have that hospital that hasn't been able to play. If we can figure out a way to get them to play, and we're still working on that, and we could add in all the other patients who are eligible, passed all the screening exams, and take them directly to psych facilities, that number rose to $2.7 million in a single year. And guess how much money those hospitals spent to realize that profit? Not even $1. This didn't cost them anything, nothing. This was all borne out on the weight of AMR and the resources provided by the county, but AMR was the large lion's share. So, where are we going from here? So, I think in the past we have demonstrated that this protocol that we've put together, and was my priority, is safety. We have developed a safe protocol that paramedics can use and be taught to safely medically screen and clear psychiatric patients in the field. Those that can be cleared, it's shown through all of these patients we've seen, are safe. None of them are going back to the emergency department because of something that we didn't find in the screening process. That, to me, was the most important part of this project so far. Now, where are we at now? We're going to keep quality moving forward, and we're going to start a publication. So there's several papers we plan on writing out of this. The first one will come out hopefully before the end of this year. I'm aiming for PEC to just talk about the policy, talk about the protocol. I've been contacted by the state of Washington, Minnesota, several places that say, what are you doing? And can you share your protocol with us? And then finally, the future. My favorite movie, The Matrix. So everyone remembers this scene, right? What was the one thing he said? He said one word right here. More. We got to have more. So we have to figure out a way to build more community paramedics. Just with our Oshpod project, we were restricted, but I am running out. I've got one that's left already, another one that may change his career, and then I'm stuck, right? So I have to be able to develop more paramedics, community paramedics, to make this thing keep going. It's not going to go indefinitely. And that is not tomorrow. That's like I'm feeling a little anxious, right? And then finally, sustainability, the pennies surrounding the plant, right? We have to make this sustainable as well, which you heard about in Matt's lecture, so I won't go into that any further. With that, I'll stop. Thanks, Lou.
Thank you. In your packets, you have a case study that was commissioned by the California Healthcare Foundation that was written by Karen Shore that covers this behavioral health program. So make sure that you review that information. And again, thanks to Sandra and the Healthcare Foundation for doing that. So are there any pressing questions? Okay, Dr. Dunford.
Are these people on 5150s?
Not all of them, Jim.
Okay.
Actually, the majority of them are not now. Our law enforcement, when they realize they don't have to put them on a 5150, they didn't do that. My only request to law enforcement is it didn't require 25,000 volts or more than one officer to convince them to comply. So a lot of these folks are actually really, and Dennis and Sean will tell you, are willing participants. That was the shocker to me. I know, did that shock you guys too? I mean, they were just, once they found out what these two guys are there to do, they're like, oh man, that's all I want is help. So we didn't have to.
Did these calls begin though on the law enforcement side, and then they request you guys? Because a lot, for our typical cases of, you know, suicidal stuff, PD are there and they're going to screen for violence and then maybe go from there. So was police always on scene?
Not
initially?
always on scene. Do you guys have a feel for how often? Is it about 60%, 70% they're on scene? Yeah, not all the time, because if it's a suicidal patient that entered through, like, say, like someone's, you know, a mom discovered their son came home from high school. I'm sorry, that's a bad example. Came home from college because they would be out of age range and is suicidal. Right. She would call 911. We would go out there as a 911 dispatch. PD would never be involved. Then our providers on scene through AMR would recognize that, oh, this is a person to be a good person for the study. They would then engage the mobile integrated healthcare paramedic. And these guys are monitoring the radio all the time, so they're often right around the corner.
That's interesting, because in San Diego, I think law enforcement would always go on that call, and they would have no recourse but to cuff the patient up and put him in a black and white and take him someplace. And we've actually done something a little bit with our RAP program. We've actually got a psych emergency response team person who has 5150 authority. And when they're not dangerous, then the police will release them to us, and then the medic will drive in that person. But once they've got that 5150, somebody's got to be with them. So these are all yours are all voluntaries, it sounds like, huh? Yeah, okay.